Dr. Sanchez Mendiola, Presidente. It's an honor to be here at your illustrious academy. Lo siento, no hablo español muy bien, so I will speak in English. But it is an honor to be here visiting your wonderful country and part of your academy. I'm very looking forward to following as much as I can of the presentations today. I learn so much when I hear others talk about the work that they're doing in this space. But to start us off, just as a disclosure, I am a full-time employee of the American Medical Association, but I want to recognize that what I'll be delivering today draws not only upon my own work, but that of our colleagues across the United States that we work with to innovate in medical education. Most of the resources that I will refer to are available online, open access, which can be very helpful to any groups that are trying to incorporate some of this work as they move forward. So I was asked to provide just a general introduction, and so what we'll talk about are some of the basic concepts and the evolution of AI in healthcare, but you will have in-depth presentations throughout the program on each of these objectives that we will cover today. So this is just an overview. So what is artificial intelligence? You'll find many, many definitions regarding that. These are a couple that I think are useful. So dating back to the 1950s when this concept was just being developed, the use of computers to perform tasks that typically require reasoning. So thinking the way humans think, but doing that using computers. And then the more recent explanation is below there, the notion of using hardware as well as algorithms and data sets to create intelligence that help us do our work. So just to cover some of the basic terms, we talk a lot about artificial intelligence, and there are multiple different dimensions within that larger umbrella. So machine learning is a process that applies statistical and mathematical modeling techniques and approaches to automatically learn and improve prediction of target state without explicit programming. Within that, what's really pushing our advances is the notion of neural networks and deep learning. So this is a specific type of learning in which there are nodes to mimic the biological nervous system of humans. And so what you see here are multiple layers of reasoning. So a computer can use different strategies in different lanes working parallel at once and then merge that together to create output. But these hidden layers are the part that is a bit of a black box for us as humans. We don't entirely understand how the data is getting used in different ways by those algorithms. So this is one of the things that physicians in particular struggle with in terms of adopting AI. Generative AI, which is your main topic today, is one form of AI, and we will use all the different forms in healthcare. But what's different about generative that people have noticed it, and really we've had an increase of intention over the last couple years, is this notion that it emulates what we do. So it can create new content based on being trained on old content, and it's essentially predicting what a human would do or say or create in that situation. So many of us became aware of AI more personally at the level of the ChatGPT, these generative pre-trained transformers. So as physicians, we certainly don't need to necessarily be computer scientists. We will need some physicians who are computer scientists to lead this work. And so thinking about how much do each of us need to know depending on the type of practice that we are in and our roles within our health system. So the more leadership one has in determining how a health system works, the more sophisticated you might need to have knowledge around these things. But what every physician should understand is the difference in how machines learn from how we learn. So these are several ways in which machines can learn. So supervised learning is the most familiar to us in terms of computer programming. This is what the more controlled situation that most of us would think of in that condition of providing the computer information and teaching it directly to do a particular task. Unsupervised learning is fascinating, but also unusual to us. And so that is providing a large data set to a model and allowing it to sort of play in it and look for patterns and look for outliers. And so the algorithm is actually discovering knowledge itself as opposed to being directed to if this, then that. It looks at a set and tries to understand patterns within it. Reinforcement learning is very task-specific, where you train around an individual goal. And so it is supervised learning, but taken to an additional step where you can really target a given task. So this would be like the master chess algorithms that are out there, that they can do that thing. The other thing that I have noted at the bottom here is that these programs can be released in different states. And so once an algorithm is trained and active and developed and is being applied in some circumstance, it could be locked so that it doesn't change how it continues to approach that task over time. And that is most familiar with for us as physicians. But a continuous learning model is possible, in which as the algorithm is exposed to more data, it can shift how it is understanding the patterns. So as the data set grows and grows, it notices different patterns and it evolves. So this starts to feel more like a colleague, like a trainee that we would be working with, who continues to grow in their knowledge and can perceive new things as they get exposed to new things. But as a physician, that can sometimes be intimidating. As a surgeon, if I'm in the operating room using a given instrument, this continuing learning model is almost as though it changes in my hand as I'm trying to use it, and that makes physicians somewhat anxious. So the critical part for physicians is to understand first how any given model that you might be using was developed. We'll also get into the importance of how the data set upon which it was developed is very important for physicians to understand as well. But we don't have to create the algorithms, but we should have some sense of their limitations based on how they are created. And I mentioned that artificial intelligence relies on big data sets. That's where the real strength is, the opportunity to process data at a level that we as humans cannot. And so it can intake a lot more data and see those patterns better than we can. What we have to understand, though, in our systems is that the data that we have available to train, especially for healthcare applications, may not always reflect our actual clinical reasoning. So this is where the specificity of a given health system and the organization and the incentives within that system will vary from one country to another. In the United States, in my country, our documentation is used very heavily to provide reimbursement or access to services. And so sometimes we find that the data has been put in an intentional way, not necessarily to reflect the thinking of the doctor, but to respond to those needs for checking a box for administrative purposes. And that can lead to challenges if you're training an algorithm to predict the level of illness, but documentation is using a strategy to predict a level of reimbursement. And so we have to be thoughtful about the data sets that we're using and how that might relate to inaccurate predictions by the AI models. And so AI has been evolving over time. I mentioned the concept emerged in the 1950s, and so you can see here, and you can't read all the details of this chart, but I would refer you to this piece in JAMA. It's a very useful overview of the trajectory of AI. And it's interesting because early AI was much more aligned with traditional programming, and it's only as the capacity of the computing power has increased that we are finding new ways for artificial intelligence to develop and train itself. Now we're moving into the generative AI realm, and this is honestly, again, what caught most people's attention. I started talking about the need to incorporate training in artificial intelligence in medical training in the US in 2019, 2020, and most people said, no, that's way too futuristic. It's not going to happen. We don't need to incorporate that into our training. Now, everyone feels like they're behind because with the release of GPT and other modalities being so accessible to all of us for other activities, we recognize the need to incorporate this wisely in our healthcare practices. So again, without getting into the details of computer science, it is useful for physicians to think about the specific capabilities. And these capabilities are not all necessarily related to generative AI. They can be other forms of AI. But I think this kind of model helps us if we have a task that we're struggling with, what is the problem we're trying to solve? And then we can see if there is an artificial intelligence application that could help us do that. And as I've mentioned, generative AI has definitely been an accelerator to adoption. In the US, the American Medical Association, for which I work, performs surveys of physician sentiments around technology and other issues. And they had performed a survey in 2023 in which there was some interest, some skepticism, some caution, as would be expected. But in 2024, the data that we just received earlier this year in 2025 showed a tremendous shift in a short time. And so we see a much greater proportion of American physicians saying that AI will provide an advantage in patient care broadly. And then we see an increase in the number of people who are using it. So physicians were asked if they are currently using at least one application of artificial intelligence in any aspect of their practice. And you can see that that nearly doubled in just a year. So the challenge is that we haven't really trained any of these physicians in the fundamental concepts of artificial intelligence. And so we're charging in and trying and experimenting, which is important. But it's also important for us as leaders to encourage that physicians get a good education so they understand how to use these tools properly. When we talk about a new drug that's been developed, a new medicine, we would expect physicians to have the capacity to read a study about that medication, whether it would apply to their practice. We haven't trained physicians how to read studies about AI algorithms and what the limitations and concerns might be in using them. In the US, you see here the top gains, and I will have another slide on this, are more around the administrative functions. And I think that is a reflection of two things. One is that physicians are being cautious, that application directly to the care of patients and to clinical decision-making we may not be ready for yet, but we're very happy to offload administrative burdens like documentation or insurance processes if we can. And so that is an issue of patient safety, I think, but also it's an interesting reflection on professional identity. A lot of the things that physicians are eager to let AI do are things that we never wanted to do in the first place, all that documentation and administrative work. We aren't really ready yet to relinquish our clinical judgment and our reasoning. I did a little exploration to see what's happening in Mexico, and what I'm presenting here is not specific to healthcare, but you'll see there is a work study trends index that is published regularly by Microsoft. And so I looked at their data. It is by country, and so you can see your own and explore that a bit more. But for knowledge-based jobs, 82% of Mexican workers who were surveyed said that they are using something, which is higher, as you see, than the global average. 80% of leaders feel that their company needs to do something around artificial intelligence, but as you see, many of them worry that they don't have a clear vision about how to do so and how to move forward. This is a particularly important statistic for all of us to think about. So this is a notion of BYO AI, bring your own AI. And so many users, many workers are bringing applications into their work without the knowledge of their employer or their organization. In healthcare, this has led to some challenges because we have protected data about patients and populations and communities. And if a worker who hasn't been trained inadvertently puts protected data into a public AI platform, it can release information that we are charged with protecting and maintaining privacy. And so this is, again, a danger zone where people are trying and exploring without having been trained on the limitations, the risks, and without getting help and guidance from their organizations. Organizations know this is the future. They don't want to hire people who don't have these skills. So we are, as leaders, charged with finding structures and providing frameworks by which we can use these things very usefully and safely because they are powerful and will help us in our work. The American Medical Association prefers the term augmented intelligence rather than artificial intelligence to really emphasize the fact that the ideal world is when the human leverages the artificial intelligence tools in a way to optimize the care for patients and for populations. So thinking of artificial intelligence as a tool to enhance our work but not replace what we do. This is a concept that's been described since, you can see here, 2009. Chuck Friedman, who talked not so much about artificial intelligence, but just informatics broadly, that a physician powered with the knowledge of other physicians, other disciplines, other people around the world, which is essentially what the cloud represents, it's our collective intelligence, that physician will perform better than a physician without those tools. Oh, so I was just making the point that that equation is only correct if that physician has been trained appropriately on those tools. Otherwise, the tools could cause trouble. So why do we need these tools? If it's concerning, should we just hold off? I mean, you hear that a lot, that people say, well, it's not safe, I'm concerned about various aspects of this, maybe we shouldn't do this. But if we're honest with ourselves, we are falling behind. As medicine has become more and more sophisticated, there are many, many more data points about an individual patient than we can process as humans. So this is information dating back to the early 2000s as well, that just represents our human cognitive capacity and what we can juggle in any given moment versus where we're headed with all of the detailed information that we have available. And you can see that this slide doesn't even reflect the contextual information of the patient, so those social determinants of health that also have a tremendous impact on what happens with our patient outcomes. So we are a bit overwhelmed, and that's where having a tool that has the capacity to deal with more data could be very powerful for us. We also have systems challenges, and again, this is something that probably varies based on where you work and the country that you're in and the way your healthcare is financed. But I hope some of these things will probably resonate with many of you as physicians as well. In the US, we've had a push to see more and more patients more rapidly, and so there's less time to think and reflect and look at things as a human. And so having a potential partner that could monitor things and give us a little heads up, or perhaps facilitate or streamline our work would be very helpful. So you can see here some of the things that we are challenged with in the US, and I assume that many of these are also applicable to your practice here in Mexico as well. So between the overwhelming amount of data and these systems challenges, there is real documentation that our errors in diagnosis do cause harm. And you don't need to read all of the details of this, but in the US, we've tried to actually measure the impact of errors in diagnosis, and we see here that 2.5 million misdiagnoses each year. These statistics are annually, leading to significant harm, so death and disability. So as we worry about some of the aspects around AI, we also have to confront ourselves and the limitations of our own capabilities, as well as the situations in which we're practicing and the impact that that is having. So if we can learn how to reason with these tools, we could serve our patients better. So we think about how we reason. Many of you may be familiar with this, but we have basically two processes as physicians, as humans. And for the most of our work, we operate in system one. So these are things that we quickly recognize after years of experience and exposure to many patients. You see a pattern, you can very quickly hone in on what's going on and lead to a diagnosis and treatment. The risk there, we know, though, is premature closure, that you think you've heard your pattern and you proceed along that pathway without recognizing that perhaps there's something different. And so there is the potential need, even if you recognize a pattern, to pop over to system two. So system two thinking is slower. That is, I don't entirely recognize what's happening here. I need to pause, gather more information, double check my assumptions, and think a little bit more, gather more help and assistance. And so system two is very valuable for safety, but if we always operated on system two, we'd be too slow. So we do need both of these, and the real key, and you'll see the most sophisticated clinicians understand when they should switch from one to another. There's almost an internal thing that hits you that says, wait, I need to slow down. Something about the case grabs you. But if it doesn't grab you, that's where many of those errors come in, because you've proceeded without slowing down and thinking through. So if we think about artificial intelligence, it could help us in several of these aspects. It very quickly recognizes patterns in larger data sets. And so if we compare our pattern recognition to perhaps what the AI is thinking it sees, it would just give us a quick sense check. It might serve as a prompt of when should we do the executive override to slow down a little bit. If we were able to get a flag to say, perhaps you didn't think about this patient's context as you're proceeding in your reasoning. And the same thing is also a risk, that we don't want physicians to abdicate our responsibility entirely to the artificial intelligence. And so we shouldn't take the quick answer from the artificial intelligence without critically appraising the output and thinking about whether we agree with it. And then finally, in calibration, this is particularly important in training, but throughout our practice, comparing what we came up with truth, whether we know that from the results for a given patient, it's just how we've historically had to do it, but perhaps what we're seeing in our residents in the United States is that they are coming up with their diagnosis and then asking AI and comparing and saying, oh, I missed this, I perhaps should have thought of that. So when we think about improving diagnosis in healthcare, artificial intelligence could help us in multiple ways. There's some foundational literature around reasoning and partnering, and then it will be a tool that we can use to improve. Another reason we may need artificial intelligence that I referred to briefly at the beginning is the physician burnout. And so in the United States, a lot of our burnout is related to administrative burden, being asked to do things that we don't see as part of our connection with the patients and the families. That's why most of us pursued this career. And so this is our framework around burnout, and you can see that the less optimal versus the more optimal engagement of a physician in their system. So having some assistance from AI to improve our efficiency and work resources, to deal with our workload and the demands of our job, to help with our organizational culture, to demystify and take away the pressure for perfection. These tools recognize that we're all learning and we all need assistance. And then providing us some control and flexibility in our schedules, all of those things could improve physician burnout if we learn how to use these tools well. So how are we actually using the tools? One of the things I like to do when I'm working in these talks as I go around the world is to generate images with AI. So this is an AI-generated image. I asked it to envision the future of team-based care in 2030. So it's somewhat entertaining to see what AI comes up with. It also very quickly shows you biases in the training data sets. As you start to explore with these, the types of people that it puts in the images, the types of thing it emphasizes, belies some of the training that it needs to rely upon to do a task. So one of the examples that I like to point out here is that you see all this technology in this picture, and yet everyone has a stethoscope around their neck because that's the sign of a doctor, right? And so the only way generative AI could show you that this was the doctor was to put a stethoscope, but they probably wouldn't use that tool given what you're seeing in this room. Perhaps they would, but so again, playing with these tools helps us understand the limitations and the risks. In the United States, at the American Medical Association, we have a collaborative across specialty societies, and so we asked those groups, how are your constituents using AI? Again, this is a list that you won't want to see all of the details, but the top uses, regardless of specialty, among these specialty practice groups were administrative, as I've listed here. So multiple opportunities to offload those tasks to allow physicians to focus more on their patients and their clinical work. Some are using clinical applications, not so much for direct decision-making, sometimes in an advising capacity, but more to, again, test ideas, think things through. So AI can kind of become a partner if you're not in a group of physicians and you're working on your own. You can bounce ideas off of it and have a conversation as though you would with a colleague. And so many physicians are using it in that way, not entirely relying on what AI might tell you to do. And then it does have significant applications in research. Again, the ability to process data, to extract data that is currently in forms that we can't easily use is another valuable aspect. Those specialty societies also expressed their specialty-specific applications, and you'll hear more about those throughout your talks today as well. And so when we think about the first slide, the foundational that everyone's using is the training that all physicians need. How do we understand those tools and their risks? Because if we go back to this list, a lot of physicians think that the administrative tools would be no risk. But we've seen significant impact in the United States if an administrative tool is a gateway to access to care, and it is ill-designed or not trained on the right kind of patient population, it can have real impact on patient health. And so we need to have, everyone needs to have an understanding to use tools like this. And then as one dives into your specialty, you learn very specific tools for those tasks. So ideally what we want to do is really leverage the complementary strengths of what AI is good at and what humans are good at. As I've mentioned, AI needs a lot of data. It needs lots of examples, very little variance in the pattern. It's trying to find stable patterns. And then that's good to give it a big data set and pull out those patterns for us so we don't have to pore through to figure that out. And so recognizing what its strengths are versus our system two. Our system two is our slow down. Think about it, we don't have enough information here. How do we get more information for this particular context? So physicians will be more important as humans in complex cases that require more thought. The challenge will be to ensure that we create a workflow that allows for that, because as I said, our typical day we get through because a lot of it we can do in system one, and then we slow down occasionally for some more complex patients. If your entire day is those more complex patients, we're going to need a new mental model about how much time that takes so that we can do that. So our workflows have to adjust in order to use these things well. So let's talk about some of the barriers as well as facilitators to adoption. So I like this slide that basically talks about the user needs to have a desire to use the tool. They have a reason to use it. They have to have the resources to access it and use it, and then the methodology to actually use it well. And so when you talk about artificial intelligence, many people recognize the risk for bias and disparities. Again, this is AI holding a mirror up to us as humans. In our current human decision-making, we do have bias and disparities in our health outcomes. And the training of the AI is the data that we give it. And so if that data is biased for one reason or another, such as the images of physicians on the internet always having a stethoscope, then it will incorporate that. It's not as though AI directly possesses bias, but it's really the risk in the way we present data and give it to the AI to learn. We have challenges around understanding how the AI works, and as physicians, we feel like it's our job to teach our patients what's happening and be able to explain things. And so increasingly, these algorithms are being developed to explain themselves, which is fantastic. It can give you an answer and then say, this is where I found the information, so that you can judge those sources and decide whether you want to take that answer full faith. Data set I've mentioned many times, and this is a very critical element, and hopefully you'll hear it throughout this convening over the next couple days. The availability of data, any potential errors embedded within the way the data was created, errors in how a human processes that data to submit it to artificial intelligence. Data needs to be labeled in many cases, and that can take time and resources to show AI what's a good result and what's not a good result. So as we charge forward, the biggest physician gap is data literacy. We don't have a lot of training in how data works and how all the things, we just think of data as pure fact, and it's not. There's errors and there's omissions and there's mishandling of data that can really impact these algorithms. So this is an imperative for physicians to understand better, and all of us will need more training in that. We've alluded a few times to infrastructure and workflow. AI is not cheap. There are more and more open access resources, which is fantastic, but it does require computational power, and that computational power resources rests in certain places. So collaborating across institutions to centralize those resources is going to be important in the future, rather than trying to reproduce it at each institution. We've also alluded to the impact of workflow. If we create these tools but don't adjust our workflow to accommodate a careful, critical appraisal of what the tool is telling us, then we will not have good results. Now, we have a great example of work that we've funded at the New York University in the United States, a leading thinker in this space, where they've been able to develop a process by which, as their medical student is typing a note into the electronic health record on a patient, that an AI algorithm is reading the note in real time, understanding the key concepts, and finding from the student's curriculum key sessions that they might want to go back and revisit in order to care for this patient. That's fantastic if the learner has the time in their busy workday to go and look at those resources, and so we might have to adjust our workflow. We have significant concerns around regulation and governance. In the United States, we worry a lot about malpractice and accountability of the physician if they're using these tools. On the flip side, as this becomes more and more powerful, one could be charged with malpractice by not using these tools and not appropriately incorporating them. And so there's a lot of questions in that space, and we need guidance at the international level. And then this notion of monitoring an algorithm over time. We mentioned that some of them are continuing to learn and adjust, and then others, even if they are, quote, locked, may become irrelevant if the population is shifting or the data is changing. We talk a lot about keeping a human in the loop to monitor artificial intelligence, but that in and of itself has some limits. We are really not good at monitoring when things are generally going well. We respond to incidents. That's what draws our attention. And so if you have a human in the loop, you almost need to automatically embed errors to grab their attention so that they stay vigilant. And then there are significant concerns, not only for trainees, but particularly around trainees, of de-skilling. If you use AI to do certain tasks and the learner never learns that task, is there something within that task that was valuable to their development of clinical reasoning and judgment? And so we have to learn and study those things. And then there are relational considerations. We talked about collaborating as a partner, the human and AI, but that does shift our professional identity of who we are as physicians, and it changes relationships. Ideally, if we use these tools well, we would be able to refocus our energies on our patients and the families and spend more time with them. But we'll have to consciously manage how this feels to us in addition to cognitively what we see. There are many facilitators for adoption of AI, and again, I don't want to get in all to the details. This study is available online freely. This is the physician sentiment report from the AMA, and you can find it on the internet if you're curious about more of these. What I've highlighted here is receiving appropriate training. So kudos to your academy for starting to think about this and talk about this together, because training is critical. And we are also applying AI to educational tasks. So not only do physicians need training in artificial intelligence to care for patients, but educators need training in artificial intelligence to improve the way we train our students and our graduate students as they move throughout their careers, as well as our practicing physicians. So we've created a small handbook that talks about key steps to think through. And you'll notice the biggest thing to point out here is starting with the problem definition. Right now, AI is exciting and it's shiny, and we want to just find an AI and then find a reason to use it, and we should be doing it the other way around. What is the problem we're trying to solve? What's our pain point? And then is AI an appropriate approach? So I will briefly talk about the implications for future training, although I know you have a session tomorrow from your dean that's going to get into this much more specifically. So I just want to acknowledge that. But at the American Medical Association, as I said, we're thinking about these in two different ways. Not only what training in AI do health professionals need to do their job well, but also how can we use training to make education better? And what we see is a future in which learning and work are much more tightly integrated. We often think of learning as something like this. You go off to learn, and then you go back to work. And these tools are going to make it much more on the fly. Based on what you're doing in real time, you could learn something in the moment. And that's exciting for us, but it will need to change our processes. So you'll see that some of the competencies that have been suggested that physicians need to leverage AI well reflect some of the concerns that we mentioned on the previous slide. So physicians need to understand how AI is trained, how it works, what are the limitations in data so that we can understand how much faith we put in any given recommendation that's provided. We need to be very conscious of the social and ethical implications, and then we've talked about all of these other issues. And so the really critical aspect is that as we're experimenting, we need to be talking with each other, sharing our strengths and limitations, questions, pitfalls, so that we can advance this together. And the strategies that we see at the American Medical Association are exactly what you're undertaking today. It really takes an institutional level conversation to overcome the risk of individuals diving in and experimenting without much guidance. And so providing leadership across disciplines. I understand your academy has interprofessional representation. That's really important because these tools are applied in an interprofessional context. And so thinking about what are the organizational structures that could be in place to safely allow people to dive in and start to experiment. We do have some resources available. We have basically a landscape analysis on where we are with artificial intelligence in healthcare. The AMA has created some free online modules. It's a series of 7 modules that are the foundations of how AI works that can be used right now by educators if they haven't developed their own resources yet. And then finally, as I said, we at the American Medical Association are intrigued by the notion of precision medical education, in which data from your own practice, or if you're not in practice yet, your own experience and training leads to recommendations specifically for you so that you can really address our unknown unknowns, the gaps in our knowledge and our practice that we might not be aware of on our own. So this is a framework that we're promoting at this time.